Good afternoon, everyone. I will share with you the analysis of the first cycle Bioequivalence rate and major BE deficiency encounter from bioequivalence perspective. Self-introduction. I'm a team leader from Division Bioequivalence 1, OB, AGDD. Learning by sharing. When I prepare this presentation, two questions pop up in my mind. Number one, what is the first cycle Bioequivalence rate? Number two, how we can improve first cycle Bioequivalence? To answer those two critical questions, I will present the information as outlined here. Number one, purpose. Number two, data-driven outcome. Number three, tips that could improve first cycle Bioequivalence. Number four, summary. The more review cycle during the review process, the longer time to achieve Bioequivalence. Therefore, we'd like to share with you first cycle Bioequivalence and the major BE deficiency type encountered, along with those suggestions how to avoid those deficiencies. We retrospectively assess the submission quality and commonly observed BE deficiency from 729 ANDAs submitted during GDD 3 year 1 and identify 82 ANDAs are BE inadequate. One review cycle is defined as FDA received the application to the first CR letter with either BE inadequate or BE adequate outcomes. The first cycle Bioequivalence rate is 87% for 335 ANDAs assessed by OB. Out of 82 BE inadequate ANDAs, 57 and 43% were classified as a BE major or minor deficiency, respectively. All right, it's a busy slide. However, we'd like to present the BE major deficiency themes from an overview perspective and summarize as a 7+1 top themes as in this graphic. Most of the deficiency themes are inadequate in vitro or in vivo BE studies and method validation as well. We also identify the impact from other disciplines, include data integrity issue, identified by oath inspection, or the batch not acceptable as determined by OPQ, or exhibiting with a safety concern by Pharmacologist. We will further explain the major BE deficiency by using case scenario with tips how to avoid these pitfalls. For example, in case number one, the statistical result provided by applicant only include 2 decimal places, where as our BE assessor found that the study failed when conducted confirmatory calculation applying 4 decimal places as a specific recommend in guidance. Please note that all in vivo BE study and in vitro dissolution testing data are considered invalid once the biobatch has not been found acceptable due to many reasons, such as the API source has a CGMP issue, or drug products quality or stability issue. We found one case that the capsule stick together became too yellowish during the storage, so the batch is not acceptable. So all of the study considered invalid. So please see the tips here. wisely select API suppliers. Ensure your drug product's quality and stability, and maintain the manufacturer side compliance. In this table, we summarize each BE major deficiency themes, followed by sample deficiency with the tips. For example, when exclude a subject data under product deviation, we suggest to submit a full investigation report from both bioanalytical or clinical deviation perspective. The key points here with the real-time evidence, including your statistical plan. For those easily correctable deficiency, we suggest that before submission, carefully check if BE study report or data are complete and consistent as possible. For example, double check if your SAS data set submit as a CDER format. In many cases, you can avoid easy correctable deficiency. PSG is a useful resource to avoid those BE deficiencies. For example, original PSG include only one in vivo options. However, the revised PSG including both of in vitro and in vivo options. So you have more options. For those complex drug products with a challenging issue, we encourage you to discuss with us on your BE strategy before submission by appropriate approach. Of course, you may also propose alternative in vitro or any in vivo approach with a scientific justification. So here we have some so-called challenging question, but I think simple question here. Number one, the first cycle BE adequacy rate. The answer is simple, C. So these are a little bit challenging. In which of the following scenario could a biobatch still be considered acceptable? I better give you the answer quickly, okay? Age batch with appropriate stability, the rest of unacceptable. So in summary, the data-driven outcome indicate that first cycle BE adequacy rate is about 87% for 635 ANDAs assessed by OB. Please consider those tips in slides number A to 12, not K to 12, in the presentation. Let's work together. For example, communicate with us by appropriate approach on your BE strategy to bring effective, safe genetic drug products to American people. I appreciate my OB colleagues, especially Utpal, Tao, Chicha, Sri, Zen, Bing, and Pasa, for their help on this presentation. Of course, I appreciate all OB assessors and project managers. Without them, the data cannot be collected. Thank you. Let me turn this stage to Priyanka.